So I am now pleased to introduce our next speakers, Tom Hill and Cece Spitznas. Tom is a Senior Policy Advisor in the Office of National Drug Control Policy, a component of the Executive Office of the President. He joined the National Council for Mental Well-Being in March 2017 as Vice President of Practice Improvement and previously served as a presidential appointee in the position of Senior Advisor on Addiction and Recovery to the SAMHSA Administrator. Cece Spitznas is Senior Science Policy Advisor in ONDCP. She provides policy analysis and scientific advice to the Director and Chief of Staff on special matters of concern such as emerging drug trends and demand reduction, and helps to develop legislative responses to problems of national scope, particularly on prescription drugs, heroin, and fentanyl. We're so honored to have them with us today to share the administration's drug policy priorities.
Good afternoon, and thank you so much, Catherine. My name is Tom Hill. I'm going to be co-presenting with my colleague, Dr. Cece Spitznas, and I will get us started. So let's go to the next slide, please. So we're going to talk today about our high-level policy priorities, and then we're going to drill down on some of them. But just a little primer is that that through our National Drug Control Policy Authorization Act of 1998, it states that the director shall release a statement of drug control policy priority in the calendar year of a presidential inauguration, following the inauguration, but not later than April 1st. So that's a long way of saying that right after the inauguration, we got busy on our priorities and got them finished in time to deliver them to Congress at the deadline April 1st. And if you move to the next slide, please. So a little bit of background is that our policy priorities, they're really focused on the urgency of the overdose epidemic, which we all know is rising at alarming rates and something that we chose to address in our priorities. And the second part is really what's achievable in the first year of this administration. So we designed them in a way that additional items can be folded into our 2022 National Drug Control Strategy that is due in February of 22 and that we're also currently working on. We also do not have a Senate-confirmed ONDCP director. We have an acting director, Regina Lavelle, who is guiding us on. And we're working with a lot of federal partners, agencies who also do not yet have Senate-confirmed leadership, and that will change things considerably, and we're acting in good faith until then. So I'm going to go to the next slide and then the one after that, and review the sort of high-level priorities, and you can see that 4 of them are in red, and those are the ones that we're going to drill down on. So just around the block, look at them is the first one, expanding access to evidence-based treatment. The second is advancing racial equity issues related to drug policy. The third is enhancing evidence-based harm reduction efforts. The fourth, supporting evidence-based prevention efforts to reduce youth substance use. The fifth is reducing the supply of illicit substances. Sixth is advancing recovery-ready workplaces and expanding the addiction workforce. And the seventh is expanding access to recovery support services. So we decided to do 1, 2, 3, and 6 and review them in greater depth, just so you get a deeper taste of what we're talking about here. We can go to the next slide. One of the things that we, in our policy priorities document, that we sort of highlight is that in each section, each of those 7 sections, we have introductory chapters, and we talk about that we create the policy and have budget oversight authority, but we typically rely on agencies to fund programs and implement policies. And there are a couple of exceptions there. We have grants featuring coordination of high-intensity drug trafficking areas. We call them our HIDA grants, and the drug-free communities, which is the DFC. So those are our grant-making capacity. I'm going to turn it over to Dr. Spitznas to talk about expanding access to evidence-based treatment, and she'll go into some greater depth for that.
Thank you. And I just wanted to say that we selected the items that we're talking about today here because we thought that they would be of great interest to the NIHCM community and plans in particular. So, you know, obviously expanding access to evidence-based treatment is incredibly important. And I'm going to go over these in depth just so that people will have a real flavor for what we're interested in doing. First one has to do with removing unnecessary barriers to prescribing buprenorphine and identifying opportunities to expand low-barrier services. So really meeting people where they are, and in some cases that's, you know, quite literally where they are. If they might be on the street, making it very easy for them to attain treatment. For example, they might come to certain services programs to get buprenorphine. We've already done a little bit of this in that you may have read that HHS issued a guideline on prescribing buprenorphine so providers could prescribe without going through the regular training that is necessary and paperwork that is necessary. They simply need to notify HHS and DEA of their intent to prescribe to up to 30 patients. And they can start prescribing buprenorphine right away. Our next one, review methadone treatment policies and develop recommendations to modernize. This is something that we feel very strongly needs to happen. Right now, there's a number of barriers in methadone treatment policy that keeps people from being able to access care. And, you know, an example of that, one thing that we were able to do during the pandemic was to offer people other options for take-home than they normally would be able to get for their doses to help improve access. Expanding access to evidence-based treatment for incarcerated individuals by working with Congress and the Interagency is something that's very important, especially considering how many people overdose when they leave prison or jail. Publish final rules this year concerning the telemedicine special registration and methadone vans or mobile narcotic treatment units is what they're called in the regulation. Evaluate progress that's been made since 2016 Mental Health and Substance Use Parity Task Force recommendations and identify next steps. We know a lot has already been done on that, but we need to really clarify what has been done. Develop and establish a working relationship with payers and employers to promote full implementation of the Mental Health Parity and Equity Act to eliminate discriminatory barriers. I hope I got MAPIA right. I should just say MAPIA. Identifying and addressing policy barriers related to motivational incentives for stimulant use disorder. As many of you may know, that's one of the most efficacious treatments available, and we need to work on eliminating policy barriers related to that. Next slide, please. Sorry. Exploring reimbursement for motivational incentives as well as digital treatments. We've already gotten an extension on the opioid public health emergency declaration, and we're also going to be exploring and trying to determine what we can make permanent related to the emergency provisions implemented during COVID. Especially, we're concerned about telehealth and the methadone policies that I mentioned before, and exploring and identifying barriers and establishing policies to help pregnant women with substance use disorder access prenatal care and addiction treatment without fear of child removal. So these are some things that we will be working moving forward. Tom?
No, I think you do it.
Oh, am I doing equity? Okay, I'm doing equity too. So advancing racial equity issues is something that's woven throughout the policy priorities document. but we have some real data needs that are in here in a standalone policy priority. So identifying gaps related to drug policy to target unmet needs in diverse communities. The first executive order that President Biden signed of this administration had to do with equity, and we are working closely with the Equitable Data Working Group on this. Establishing a research agenda to meet the needs of historically underserved communities, establishing an interagency working group to agree on specific policy priorities for criminal justice reform, very important issue right there. Identifying culturally competent and evidence-based practices for Black, Indigenous populations and people of color across the continuum of care. We are also going to be working on reforming how we do our drug budgeting so that we include an analysis of how federal dollars meet the needs. And next slide. Sorry, I keep forgetting the next slide. There we go. Directing agencies to begin collecting budget data disaggregated by demographic category. That is so that we can see how the money is being spent and ensure that the money is going to the people who are most in need of the money. And then finally, promoting integration of the standards for culturally and linguistic appropriate services in health and healthcare for providers of treatment, prevention, and recovery support services, starting with a review of the standards by executive departments and agencies with healthcare roles. So that, really has to do with making sure that people who are providing care in a manner that is culturally appropriate, and people can actually speak to the people that they're serving. So these are some issues that we think are unique. We've never had advancing racial equity as part of the ONDCP priorities before, and we're really excited about this part. Okay, now I'm going to turn it back over to Tom. Yes?
Yes.
There we go.
Thank you, Cece. So I'm going to go to the next slide, and we're going to talk about enhancing evidence-based harm reduction efforts. So this is our first time for policy for the ONDCP to highlight harm reduction. And when we talk about harm reduction, we're basically talking about syringe service programs, or SSPs. We're talking about fentanyl test strips, or FTSs, and we're talking about naloxone availability. And the reason, one of the main reasons we're looking at harm reduction as a policy is because it is a way of engaging many people who would not ordinarily be coming through the portals of the healthcare system or the treatment system. And so it's a way of engaging people into healthcare and treatment, often for the first time, and often through a very low threshold manner of entry, not a lot of requirements, and a way to treat people without judgment, without shame, let them come to the door and help them with what they need. So the first one is integrate and build linkages between funding streams to support syringe service programs. That's really on a federal level across programs, CDC, SAMHSA, and other agencies to start connecting the dots that exist in a way that makes sense programmatically and on a policy level. Second is to explore opportunities to lift barriers for federal funding for SSPs, particularly for the barriers against being able to not spend federal dollars on supplies such as syringes. The third is identifying state laws that limit access to SSPs, naloxone, and other services. So we know that many states in recent years have changed their laws that now make syringe service programs legal, but sometimes the other state laws are inconsistent with this. They may have paraphernalia laws that include syringes or fentanyl test strips and make them illegal, even though they've legalized safe SSPs. So to do some work to make those laws align so that people who are practicing in those service provisions are able to do so without any kind of barriers. Third is, the next one is examine naloxone availability in counties with high rates of overdose. So looking at those counties, seeing what the naloxone availability is, and then identifying opportunities to expand access in target areas. Among pharmacies, clinicians, peer support workers, family and community members, and people who use drugs. And then on this slide, the final one is amplify best practices for fentanyl test strip services, standards for fentanyl test strip kits, and use of fentanyl test strips as a means of engagement into healthcare systems, as I talked about earlier. Let's go to the next slide, please. So the remaining two in this area are develop and evaluate the impact of educational materials that feature evidence-based harm reduction approaches. So looking at those educational materials that link people who use drugs with harm reduction, treatment, recovery support, health and social services through a diverse range of community members, and looking at what a team of community members might look like in terms of how to train law enforcement officials in evidence-based approaches that address overdose and provide police-assisted recovery. And then the final one in this area is supporting research on the clinical effectiveness of emerging harm reduction practices in real-world settings and testing strategies that best implement these evidence-based practices. So looking at the whole range of practices, emerging, promising, best, and moving them up to an evidence base. And then the final one we're going to talk about, if we switch slides, we're going to go to the sixth policy priority. And that's advancing recovery-ready workplaces and expanding the addiction workforce. We're going to start with the workforce and talk about request federal agencies to support training for clinicians in addiction with special emphasis on community-based services in underserved areas. So that would be like the Veterans Health Administration, such as federally qualified health centers and the Indian Health Service. And the sub-bullets on that are to identify authorized vocational programs that can expand the addiction workforce and evidence-based practices that have not yet secured appropriation. So we're doing that now. Some of those were named in the Support Act, but the appropriations were never made. So we're getting those aligned with appropriations so that they can be funded. And the other one is to explore opportunities for training bilingual immigrants who were addiction professionals in their home countries to become case managers. So I want to say also, take a moment to explain that all of these policy priorities came from not only our best thinking, but we in February convened a series of stakeholder roundtables to get people in the field best thinking about how to enhance these priorities. And that one in particular came directly from one of our stakeholders in a roundtable. The next one is to seek opportunities to expand the workforce of bilingual prevention professionals and peer specialists by offering incentives to train and identifying barriers to treatment and prevention for populations with limited English. So another thing to think about is that even though equity is its own policy priority, it's woven into all of these priorities in various ways. So when we talked about access and we talked about language, we talked about barriers around people with limited English. We're talking about a lot of health equity issues and even social determinants of health. So if we go to the next slide, this one has more of the recovery focus, and it identifies ways in which federal government can remove barriers to employment and create employment programs for people in recovery from addiction. So our thinking there is if we can figure out how to make this work on a federal level, we can really role model that out to the field and to labor in a way that makes it achievable, but also something that's attractive in terms of how to do it and why to do it. The second is to conduct a landscape review of existing programs, because there are many states that are doing recovery-ready or recovery-friendly workplaces, as well as to local governments, employers, and members of the workforce, and offering grant opportunities that support recovery in the workplace and remove hiring and employment barriers that exist, and provide recommendations to ensure all communities, including rural and underserved areas, have access to these recovery-ready programs. We need to identify a research agenda to examine what the existing recovery-ready workplaces look like and how to evaluate and research them. And then finally, to produce guidelines for federal managers on hiring and working with people in recovery from an SUD. That is connected to that first bullet on this slide, is to a lot of what's required in recovery-ready workplaces is not just hiring and training, but also training employers and staff how to be a part of a recovery environment or a recovery culture that exists in the workplace. So that is our high level and drill down on 4 of the 7 priorities. And I know we're going to have a section for Q&A, but I think we're going to have another speaker before we do that. So thank you very, very much. Those are our contacts. If you need to get a hold of us to learn more or get more detail, we're happy to do that.
Thank you so much, Tom and Dr. Spitznas, for sharing the administration's priorities and this bold approach to strengthening the nation's approach to prevention and recovery.